Good morning. Thanks so much for the kind introduction and the invitation to be here. Wonderful to be in a room with so many distinguished colleagues to talk about this important work. Being back at WashU is always great. This is where, as you heard, I started my career. Dr. Morris was my Career Development Award mentor, and so I grew up in the ADRC here. Wonderful to see so many colleagues that had a great impression on my career. This is also where I learned about community engagement and involving the community. So hearing Reverend Strong say the salad bowl gave me a little bit of a trigger shock there. I remember times in the salad bowl getting schooled by community members on what I should and should not do, and how I did not talk about the communities correctly when I came to talk about research. So I'm very much grateful to the St. Louis community for making me pause and realize that I needed to approach my work differently. So disclosures, I do have research. You heard some of the research that we're doing, funded by the National Institutes of Health. Also have funding, I think important for this audience, from the Alzheimer's Association, and I'm going to talk a little bit about some of that, which includes the American College of Radiology. So I'm going to focus my time on some of the work that we're doing in the Recruitment Innovation Center, which is led out of Vanderbilt, as well as some of the work that I've been doing with a group of folks around the country in an Alzheimer's imaging study. But first I want to set the stage for what I'm talking about with these marginalized racial and ethnic groups. I'm specifically focusing on minoritized and marginalized groups as we think about it from the National Institutes of Health standpoint. Obviously, there are other populations that are listed here that experience disparities. I have updated it to include what was already mentioned this morning, individuals with disabilities now being recognized as a population that experiences health disparities. But the important reason for this work when we're talking about Alzheimer's disease and dementia is that we know there are disparities. So African American, Black, Hispanic, Latino, Latinx, Latina populations suffer disproportionately from Alzheimer's disease. And so I think that is really important as we talk about the diversity of people participating in studies. Who is the evidence supposed to impact? The populations that are most impacted, suffering the most, and the evidence to date is not actually supporting interventions and treatments for these populations is really why I'm focusing on these populations. We cannot continue to accept that evidence is being created without addressing the people who are suffering disparities. And so my challenge to everyone is to keep front of mind that our science is no good if we're not including the people who are suffering the most from the disease. So when we talk about race and ethnicity, we've heard it mentioned already, these are social categories. I would say this is a socio-political category when we talk about race and ethnicity. In the United States, in these United States, race has been used primarily as a way of oppressing people. And so as we continue again to think about these populations, and we as scientists, as health scientists, are wanting to put people into groups to identify issues and categorize them in certain ways, this proclivity to, let's put them in as few groups as possible so we can have enough sample size to compare them. What are we comparing? Are we comparing them based on these social drivers, these social factors, these political factors? What is race representing? Is it representing racism? And so again, as we continue to think about this work, recognizing what we're actually doing. So I wanted to set that stage before I started to talk about some of the work that we're doing in trying to address the underrepresentation, the historic exclusion of these populations from our research. Often when we think about the barriers to participating in research and clinical trials, we are putting the blame on the people who are not participating. And so historically, we've described many of these issues, the mistrust, the distrust, all of the demands, not being able to get here, not having information, not being asked, the legacy of exploitation and historical abuses. There are many, many barriers that exist. Many of them, though, created by these systems of oppression and racism and discrimination. But our focus as researchers has still been often to blame the people who are not participating for not participating. And it's, again, wonderful to be in a room with people who are starting to address this, who recognize this, and many people outside this room need to hear more about this, is that we cannot continue to accept that, excuse ourselves from being the solution. So the answer isn't just that we need to change opinions, views, give people more information, educate. Again, that's a salad bowl conversation, was like, we don't need to be educated. We don't, we understand. We're smart enough. That's why we're not coming to participate, because you all have been, marginalizing and abusing us. That's why we're not coming. We don't need to be educated about it. So, again, recognizing the systems levels, the norms that we've created, the practices, the things that we've been doing as part of our research institutions, as part of our teams. What do we need to change? How do we need to use the right language? How do we need to bring people onto our teams? And so, again, it's really great to see this work continue to move forward. So some of the work that we've been doing has really, though, focused on what do the researchers need? What do the investigators need? So many times we see people come to our Recruitment Innovation Center asking for help, but they actually think they know all they need to do already. It's like they're smart enough, they already have all the answers, but people just are not participating in the studies. Somehow that disconnect still is there. So that limited knowledge, the research teams are not diverse enough, there's no communication, all of the things you talked about 5 years ago. The lack of cultural humility, which again, we have evolved in language away from cultural competency to humility. Are we humble enough to actually accept and recognize the things that we don't know? Many of the challenges we see related to studies that are at the budget level, studies don't have the adequate, appropriate budget to do research in these communities. And that's not just with recruiting the staff or the researchers to be on the team, but even to advertise in the St. Louis American, to actually go out to churches and appropriately compensate them for coming in and using their space. So many other issues that we need to try and address. If you're not familiar with the Trial Innovation Network, it is several different awards by the National Institutes of Health that are focused on research innovation related to clinical trials, multi-center clinical trials. And so our team at Vanderbilt, I co-lead this with Paul Harris. We've been doing this now for 7 years as the only recruitment innovation center funded in this network, focused on how do we actually create new tools, resources to support multi-site clinical trials. Our strategies are really around how do we take community engagement, how do we also use informatics, digital technology to understand where the opportunities are, but inform that with community input to actually come up with more sophisticated and efficient strategies to do clinical trial recruitment. We do this on what we call a recruitment continuum, and so we recognize that recruitment begins with awareness, feasibility, opportunity, but that recruitment doesn't end after you get into the study, after you are retained in the study, but recruitment continues until you get information or value returned to you. So we created this concept called return of value, which recognizes that there are differing reasons that people participate in research and clinical trials, and we need to understand what is valuable to you in returning results and understanding what are we doing with your data, who are we sharing with it, how are we using it. And so we've developed, again, strategies along this continuum, but also, again, thinking about that with the participant and the community in mind. So one of the things that we've developed is this portfolio of resources called Faster Together. And they're really intended to increase the recruitment and retention of marginalized racial and ethnic groups. We have one resource that is an online course. It's a mass online course called Faster Together. It has 8 modules. You can take it, it's free. We just have recently finished filming some updates, so along with the earlier discussion of evolving language, so we're updating it to not say recruitment of minorities, but to say recruitment of minoritized populations. We're updating some other language, and so that updated version will be available in the next few months, but it's still currently active. We've had more than 4,000 people around the world to enroll in this course, and it was developed with community members as part of the team, and the updated version will have even more community members who are part of the course here. So hopefully people will find this important. I want to shift a little bit to talk specifically about one of the studies that we've been involved in that's focused on Alzheimer's disease. So several years ago now, Dr. Peggy Dilworth-Anderson called me to say that there was a study that she wanted me to help with. And for those of you who know Peggy, you don't really say no to her. You just say, okay, what next? And so Dr. Dilworth-Anderson and I were brought onto this team with the Alzheimer's Association and others that was doing a study, had actually already done a study looking at amyloid imaging in this large study across the country. And talking about publishers, so this study called IDEAS had more than 17,000 people in it. And unfortunately, in that original study, only 10% of the people who were in that study were from minoritized racial and ethnic groups. And so Peggy and I were asked to join the team to think about what's happening next, which was going to be new ideas. And I'll tell you about that in a second. But our first question was, well, what happened with ideas? And so there were 10% of the study, people from these minoritized groups. But in the original publication, which was in a high impact journal, they actually did not disaggregate the data by race or ethnicity. So it was published in this high impact journal. The publishers, the reviewers, nobody said, where's the data? And so one of the things that we did was to look at. So even though it's only 10% of the 17,000, it's still one of the largest studies that has amyloid imaging data from this population. So we looked at the data, and this was published about a year ago. And what we found was that for people who were Asian, Black, or Hispanic, that they were less likely to have amyloid positivity, PET positivity. And so for those of you who are, do this work, are very involved in the field, you know that has many implications. That means that if you have less amyloid or you don't have amyloid, then these newer treatments that are being approved don't work, or you're not eligible for, or we don't know if they will work because you've not been included in those studies. And so here we are again in this situation where we have several new drugs, very expensive drugs, that have been approved, and we don't know that they work in the populations of people who are suffering the most from the disease. So in this next study, in the New Ideas study, we proposed that we would have, moving forward, we would have 4,000, another study with 7,000 people, 4,000 of them would be Black, and Hispanic or Latinx, so 2,000 in each of those groups. Dr. Dilworth Anderson and I put together teams, and we've been doing this work now for several years with recruiting Black and Hispanic people into the study. Now, what I want to focus on in this last section of the talk is that this study is different because it was a CMS, so a Medicare a study. So CMS, coverage with evidence development. That means that you had to have Medicare to be a part of the study, and it also meant that you had to pay a copay, your insurance, to get the amyloid imaging, so this highly specific radiology. So it's different from the traditional research where you're recruited, we pay the cost, and there's no out-of-pocket expenses. So we went into this study knowing all of the barriers that you all talked about, the common barriers, the study-specific barriers. We had identified those. But then we needed to think about how we're going to approach this differently. So we started with, where are the dementia specialists in the country? And so we mapped that out, and we looked at the population of Hispanic, Latino people who are over 65 with Medicare, same for Black, African American people, and we tried to identify places in the country that had access. So we really were careful in identifying communities that had higher percentages of Black and Hispanic, Latinx populations. Dr. Dilworth Anderson and her team led the community engagement strategies. You can see her in the image on the right or on your left, along with Dr. Carl Hill going around the country, doing these engagement strategies in person, coming up with teams, but also we put together teams that focused on how we culturally adapt materials with participants in mind, communities in mind. We trans-created materials in Spanish, so we didn't just translate them. We started from scratch to say if we were saying this in Spanish, what would it sound like, how would we word it? And so again, working with communities. And then we had these site-specific strategies, talking with these sites around the country, helping them to work, day to day, what are their challenges and strategies. But guess what? There were still barriers to doing this work. So there are barriers that we identified during the implementation of the study. And so I think it's really important as we develop these strategies at the beginning, we realize that we have to iterate and we have to have strategies to address them. So even though we mapped out where the specialists were, there were still issues with getting people into specialists. So people didn't have, yes, we're happy to see people, but it took 9 months to get them in to study. So again, it wasn't a traditional study. The PET imaging facilities weren't taking Medicare Advantage. And so if you know the data, Black and Hispanic Medicare beneficiaries, more like about half of them are Medicare Advantage. And so they're not actually able to get the referrals. And so all of these structural issues related to racism, segregation, are showing up in the study. We actually went through this process of requesting that the OIG allow us to pay the copay, the co-insurance, because it was, again, not a traditional study, we couldn't just pay it. And so it took more than a year to go through that process that we would be able to actually pay for people to participate. So a lot of strategies that we went through. Again, I would just say it's important to recognize that there are many barriers that are underlying even what we go into this work thinking about as a highly skilled team of people who have experience with these populations. The one thing that I'll end with to say that I hope we'll see more of is that as we started to do recruitment in the study, I mentioned there are 2,000 Black, 2,000 Hispanic, and there are 3,000 people who could be of any other race or ethnicity. That third cohort, that third group, the recruitment enrollment was happening really fast, as you might imagine. So what we did was actually pause the recruitment in that group that was mostly white, while we focused on recruitment of Black and Hispanic people. So I'm hoping that we'll see more of that, those kinds of studies where we can say, no, wait, we're not going to enroll 7,000 people and then have it be mostly white again. So thinking ahead of how we can be more innovative in these kinds of strategies. Thank you for your time.